Alright, now welcome to the second video about the spleen. Again, we're going to try to cover some of these things. And in this one, we're going to talk about the various splenic diseases that we might see. So, of course, we have the normal spleen, and also something that is normal is having an accessory spleen. About 15% of the population has that. One of the other things we will talk about is splenomegaly. That's when a spleen enlarges in size. And remember, the size of the spleen is dependent on the age and the height of the patient, so you need to figure out what is normal for that person. And then we're going to talk about various disorders of splenic function, and so that could be things like hypersplenia, where the spleen is doing too much, hyposplenism, where it's doing too little, or asplenia, where you either don't have a spleen or the spleen isn't really doing anything. And then we'll also talk about some of the various focal lesions to the spleen that you can get, like splenic infarcts, splenic abscesses. Often the infarct can turn into an abscess. Splenic cysts, splenic rupture, usually from trauma, but could be from other things. Splenic artery aneurysms can happen. They're rare, but they can certainly happen. And then we'll briefly touch on metastases to the spleen. So why don't we start with splenomegaly. Now remember, we can't normally palpate the spleen because it's hidden underneath the ribs, especially the 9th, 10th, and 11th rib. And so normally you can't feel it. And it's got to be usually about 40% bigger than it's normal in order to be felt. So as the spleen enlarges, it might grow bigger than the rib cage underneath which it lives. And then you might be able to palpate it at that point. So what can cause splenomegaly? There are congestive causes which causes blood not to leave the spleen, things such as cirrhosis or CHF or thromboses in the portal hepatic or splenic veins. And we also have malignant causes where we have too many cells in here, like lymphoma, leukemias, multiple myeloma, polycythemia vera, excess number of platelets, or other things like metastases or even primary splenic tumors. And we can have infections. Bacteria, virus, parasites, and fungi can all cause the spleen to swell. With extramedullary hematopoiesis, the spleen takes over the making of blood cells in disease processes such as myelofibrosis. And autoimmune and inflammatory diseases like lupus, rheumatoid arthritis that ramp up the immune response, and especially diseases where you have autoimmune destruction of red blood cells, because we know that's going to also be taken up and taken care of in the spleen. All sorts of infiltrative disorders like sarcoid, Niemann-Pick, Gaucher, and amyloid. And even hematologic causes, of course, like sickle cell disease, hemolytic anemias, or even medications like granulocyte colony stimulating factor. And so all of these things can then lead to splenomegaly, causing the spleen to grow in size. And then this will cause symptoms like tenderness of the spleen, early satiety as the spleen pushes on the stomach, and chest and shoulder pain as it starts irritating the diaphragm. The spleen can in fact get so big that it crosses the midline and starts irritating structures on the right side, or even go down into the pelvis, displacing bowel and causing pelvic pain as well. So how do we work this up? Well, of course, we know that ultrasound can be used to determine splenic size if you have any question. Usually, though, if you can feel it, it's probably big. Especially, on blood tests, especially if blood cells are being sequestered in the spleen, you might see cytopenias on your CBC. And Felty syndrome is rheumatoid arthritis, decreased PMNs, and splenomegaly. And of course, on the peripheral smear, we might see some abnormal cells, like the teardrop cells, which are RBCs that have been pitted in the spleen and they lose their ability to keep their shape properly, and they may actually even become spherocytes. And so for treatment, we're going to want to treat, of course, the underlying cause, which we saw there could be many. No-contact sports, because we're afraid of splenic rupture. When it's so big, it's no longer protected. And that could be for a while, like 8 weeks after EBV. And splenectomy is rarely done because it increases the risk of infection as well as the risk of thrombosis. So now let's take a look at disorders of splenic function, and we'll start off with hypersplenism. And with this you have pooling of blood in the spleen. And this could be caused by something like cirrhosis, which increases portal pressure, which then ends up pushing blood into the spleen, or even thromboses, like the splenic vein, which also prevents blood from leaving. And so when you have all that blood in there, the spleen can do its job and to excess. So then all these red cells that are here stuck in the spleen, and white blood cells and all that, and even platelets, get filtered out. And so on blood tests we're going to see cytopenias. But luckily, bleeding is rare and transfusions are rarely needed. So what's the treatment? Usually it doesn't require treatment, but if it's bad enough, you could do splenic artery embolization. Splenectomy is rarely done because of the aforementioned complications of increased risk of bleeding and increased risk of infections. So that's hypersplenism. Let's look at another disorder of splenic function, which is hyposplenism, which means the spleen isn't doing all that it should be doing, or to the other extreme, even asplenia, which is the spleen isn't doing anything at all. So asplenia can be caused by many things, including a splenectomy, an infarct that kills off the entire spleen, infiltration like we talked about with splenomegaly by amyloid, sarcoid, etc., congenital absence. Most familiar with this sickle cell disease, which can cause splenic infarcts. It can also cause splenomegaly, and of course we know that cells can get sequestered in the spleen too. And all of this leads to decreased splenic function. That leads to increased risk of infection, of course, worse with encapsulated organisms. And there was a study that looked at World War II vets that had splenectomies during the war, and they followed them up to see those with splenectomies and those without splenectomies, and see what did these people die more often of. And unsurprisingly, pneumonia was one, but more surprisingly, they had a lot more ischemic heart disease. And with the spleen not doing its job, on our testing we know we're going to see a lot more of those abnormal cells that the spleen should have been taking care of. And we'll see those RBCs with the Howell-Jolly bodies, the Heinz bodies, the nucleated RBCs, as well as the oddly shaped ones like the teardrop cells and the spherocytes. And for treatment, since the big thing that is the problem here is infections, you want to give them prophylactic antibiotics, and of course they need to get their immunization so that they do not get pneumococcus, etc. So this video took us through a couple of splenic diseases, hyposplenism and hypersplenism, as well as splenomegaly. And so in the next video, which will probably be the last in this series, we'll talk about some of the more focal splenic lesions. Thank you guys for watching.